Yeah, good evening, everyone. I welcome everyone to this masterclass number 94. This is on a very common and most useful and most abused drug, which is steroid. So there are various steroids which are available in the market, and they are used by various specialists for various reasons. And whether it is really worthwhile opting for such medications when we don't know how it's going to impact or what is the basis of it, can become detrimental to the patient and also for the fertility treatment. So let's know about as to how really it will work and if it works at all, if it works at all, and then whether it is worthwhile trying this as a cheap immunomodulator, and when do we actually resort to these things when there are so many other high-end immunoglobulins like IVIG or even like thymosin and so many things, even tacrolimus. So let's know from Dr. J as to what a simple steroid, which is cheap, can actually add to your fertility practice on a day-to-day basis in non-IVF cycles.
Yeah. So I will straight come to the point. Okay. See, remember one thing. Whenever we are trying to talk about any form of steroids, all right. The first and the most important drug which we are going to talk about all the time is going to be Visolone. So I will just start writing that only. Don't want any confusion. The standard dose of Visolone, which is prescribed in practice, is going to be 5 mg BD or 10 mg OD. So I'll just write down 5 mg BD. This is the standard dose which you are going to prescribe. Of course, it is very cheap. All right. And of course, remember one thing. It is not a standard drug for stimulation at all. Okay. So broadly, when you look at any form of steroid, especially Visolone, because everybody, when they add, they are going to use this as a brand name. Okay. You are supposed to look at three situations. Okay. One is a normal response. Okay. Second is a poor response to stimulation. Poor response to stimulation, you have to divide into two. One is normal AMH, one is low AMH. Okay. Third category, immunological treatment. And fourth category is miscellaneous. Now, this miscellaneous is a very cute category. I'll come to that in a little while. See, in normal response, remember, it has got no role, no benefit, no major side effect. Okay. It's like homeopathy. No effect, no side effect. Correct? Placebo. Placebo, no role in a normal response to a natural cycle stimulation. So when I try to talk of a natural cycle stimulation, basically we are looking at a patient in whom we are going to give letrozole 2.5 along with any form of HP-HMG in a standard dose of 150 international units plus minus low dose HCG. These are your standard stimulation protocols, and majority of the patients are going to opt for ovulation induction with timed intercourse or IUI cycles. So basically, this is something which is going to help your level 1 ART practitioners. All right. So in normal response, you already got your answer. It is not going to give you any great benefit. In a patient who is a poor responder with normal AMH, most probable answer to this is going to be PCOS. And in PCOS, just remember this golden line. Okay. It may not be actually very golden, but still try to remember this line, that metformin is going to be much more beneficial than Visolone. Okay. Addition of metformin is going to really help you in your stimulation response. When you have a poor response to stimulation, that means when you have given this in a standard dose for approximately 5 to 7 days and there is a poor follicular response, next cycle if you add metformin, your response will be way better as compared to addition of Visolone. Just in case you want to add Visolone, it may or may not help. Nobody knows. Okay. Again, when we come to low AMH, there is no role, no benefit, no major side effect. Okay. Nothing. No major side. Now, In immunological people, patient is going to be, let's say, on any form of suppression, azathioprine, cyclosporin, okay, prednisolone, whatever. You can say of tacrolimus, whatever the patient is already taking. These patients who are already on immunosuppression, you need to be ensuring that majority of these patients are tapered off from azathioprine and cyclosporin and tacrolimus. And if they are on maintenance of prednisolone, especially patients who are post-transplant, especially patients who are post-bariatric surgery, especially patients who are post-severe autoimmune conditions like psoriasis, Sjogren's syndrome, SLE, renal pathologies, if they are on a maintenance dose of prednisolone, you can safely give, along with a maintenance dose, your standard drugs of letrozole and HPHMG. Now, I have had a very big experience of using it in this category, and I will tell you that even on ongoing prednisolone, this is there. There is no benefit. Okay, it does not really add anything to your response. Instead of getting 2 eggs, you don't end up getting 4. Instead of getting 2 mature eggs, you don't end up getting 3. Nothing like this. Okay, and the third category which we should remember, which comes to us very frequently, especially if you are staying in Bombay, is a patient who is on any form of chest and asthmatic treatment. Okay, now see, majority of these guys who are on chest and asthmatic treatment will have some form of steroid inhalers which are going on. Okay, which can either be, those inhalational steroids, those spray steroids, whatever. You can, and they are not Visolone, they are different category of steroids. Now, even on those steroids, basically there is no added benefit to your stimulation. The postulated theory is that, let's say you have this ovary and you have circulating steroid in the body. What is steroid going to be actually formed from? It is going to be formed from cholesterol. All right. So when you have actually circulating steroids, this presence of steroid goes and does a local action on ovary, thereby increasing its response to stimulation. Okay. As a result of this theory, we had believed that addition of this drug is going to help you in especially PCOS category of patients, but probably that is not the theory which actually works. Simultaneously, a lot of people think that addition of Visolone is going to reduce your luteal phase defects, and if it reduces luteal phase defects, it is going to reduce your post trimester abortions and it is going to reduce your biochemical pregnancies. So definitely no role in any of that. Absolutely no role in any of that. It has got absolutely nothing to do as far as implantation is concerned. So if I give you a one-line summary of the things which we spoke as far as today's session is concerned, addition of steroids in non-IVF stimulation cycles, one line, has got no role. If you add because you want to add out of your practice, or you have read it somewhere, or one of your friends whom you think is a great person in IVF and he or she is adding steroids in their practice, it is just a copy. Okay. Apart from that, practically it has got no role. But remember one thing, in an immunosuppressed patient who is on steroid maintenance needs to be continued even while you are doing fertility stimulation. Don't stop that steroid maintenance. It has to go on even in pregnancy. Do not stop it even in pregnancy. In fact, in pregnancy, after 12 weeks of gestation, when we send them back to the nephrologist, or these days we don't send to nephrologist, these days we are sending to one more who is a transplant medicine specialist. Okay, in that situation, along with steroids, they are going to add back azathioprine, cyclosporin, whatever, and pregnancy continues beautifully. Understanding? So don't get worried about all those things. Practically, it has got no role. That is the bottom line. Any form of steroid, oral, vaginal, perrectal, nothing, no advantage over the other method because nobody knows the exact mechanism of action. And I want to tell you one more thing. This steroid which we are giving now, 5 mg BD, okay, it is like a dose. I don't know what is the I don't know what is the English translation. We call it like this, okay? In our normal, really, in our Bombay, we call it like this. It's like I don't even know what's it called. So don't give it. It's a baby dose. Ecosprin, like baby ecosprin, it is that baby steroid. It doesn't work, in my opinion. Not my opinion, in everybody's opinion. Okay, but this is the bottom line, because people often think that after two failed natural cycles or after two failed IUI cycles, now I will add steroid, and I will add 5 mg prednisolone twice in a day. It is not even going to reach till the uterus. Okay, all this it will not reach only. Forget, liver will only consume 90% of it. So practically, don't get carried away with that. Yes, don't add these steroids in low AMH patients. No role. Don't add these steroids in normal AMH patients. You really want to experiment then severe PCOS patients, because we were discussing lean PCOS patients have higher resistance to stimulation. You may try to do, and see, one of patients is going to get a benefit and you will be like, I added a steroid and suddenly I got a result in the next cycle. No, yaar. In a long term situation, it is not going to help. Second, these days your patients are going to come and tell you, why are you doing steroids in my stimulation protocol? Because they will think that this steroid is going to go and cause immunosuppression. This is not even enough to balance out cortisol if somebody is a hyper human being, type A personality. This much steroid will not go and act on that person. So just keep that logic in your head and go ahead with your practice, is what I think. With that, I conclude, and probably one or two questions we can answer.
So what happens in cases where the patient has anti-TPO antibodies positive, where the TSH is
Yeah,
still not?
yeah, continue. No, see, when there are anti-TPO antibodies positive, they may give steroids along with that. Many people are giving HCQS also along with that. There is no rationale of stopping these drugs
Yeah.
in that situation. Continue stimulation. What is your HCQS going and acting on? It is not going to go and act on the ovary, no. It is going to go and act on the thyroid. It is going to go and act on the peripheral metabolism. So it has got nothing to do with all these things.
Okay. And what do you think about immunomodulation? I think we discussed this in detail when we were talking about reproductive immunology. So
Yeah.
do you believe that these NK cells are really the killer cells, and they have to kill the
No.
immunity inside the uterus, which I think will be taken care by the steroids to generally suppress the immunity of the patient? And do you think that's how the pregnancy or implantation actually, happens? What do you think?
No one knows nothing about it, madam. That is the problem. See, when no one knows nothing about it, no. Remember one thing, such type of experiments will only happen in a country like India where there is no regulation. Even if
Mm.
you go to look at the way in which people practice LIT in our country,
Mm.
it's it has got no indication. We have done LITs in our Bangalore center. I'm not saying we are not doing LITs. We are doing LITs. We are doing immunomodulatory therapies. Out of 100 patients, we'll see we'll do it in 5. Understanding, and out of those 5, it will work in 3, if at all
Mm.
it is to work. And then people will deliver. But if you say, acha, you failed 4 IUI cycles, let's do LIT. That type of things is more of commercialization and less of science.
So when we are talking about, say, adding steroid, especially these immunologists and the other like transplant physicians and all these newer generation specialists who deal with such things, especially post-COVID.
Yeah.
So do you think the viewpoint of adding steroid to these immunological diseases has changed? I mean, I
Yeah,
know.
madam, they don't end up adding, I mean, they do give steroids, but there are so many more another types of drugs which are available, those locally acting ones, that antibody combinations and all these things are available for all these patients. And a lot of people focus on those types of drugs. I know, see, we know of a lady, I mean, we've done fertility treatment for that particular lady with autoimmune hepatitis. Okay, she was getting one specific drug, which is a monoclonal antibody type of a drug. Okay, and she had to take one injection, I think, in a month or so. And she was absolutely fine. She had got clearance to do all fertility treatments after that.
Mm.
So this type of things are, the science is changing very rapidly inside immunology and immunosuppression, both the things.
Yeah, yeah. So in your practice, I mean, say between all these, like the menu of say steroid, HCQ, and tacrolimus, and also like, thymosin and all this, IVIG also, and intralipids. So which one do you end up using, like, I mean, one over the other? Say, like, if you have to name 1, 2, 3, 4, 5 commonly, or you just don't use anything at all?
Best is Ecosprin. Okay.
Yeah.
Apart from this, I don't use anything. In between, do you remember I had started giving in recurrent pregnancy loss, I was giving thymosin and I had spoken about it. I myself told after that it has got no benefit. We tried it in 15-20 patients, madam. No great benefit of giving thymosin in recurrent pregnancy loss at all. Okay. IVIG, intralipids, more of commercialization, madam. Less of science behind it. Okay. So I don't use it at all in my practice. I don't use it at all. Rarely. Maybe 5 patients in a year.
But HCQ, many people just randomly.
HCQ may be good, madam, because it will take care of, ANA titers. It will take care of, and getting a weak positive ANA titer is such a broad spectrum.
Yes.
Okay. It is such a broad spectrum. Okay. And when it is such a broad spectrum, some or the other HCQS will go and act somewhere, no, madam.
Yeah, I think this was a good session. I think we had missed out on this basic concept of adding or not adding steroid. So somebody in our level 1 ART group, they had asked about you to throw some light, and you said you'll be throwing lightning. So I think you have stuck to your words, and it was quite a good one actually. So I think I wish more people will see this class and will benefit more out of it. And I thank all of you who joined us live. So thank you till
And
we
if
meet
there
again.
are any questions, guys, please don't expect questions to be answered on live sessions, because live sessions, we are planning to keep it for 14-15 minutes. You have so many questions which you think are getting unanswered. Question them on WhatsApp. Any which ways we are answering it and helping all the people out on the WhatsApp groups.